All right, higher time for the diabetes tutorial. So, two excellent quotes about diabetes that I found online. Diabetes care is like jazz. It's structured, it's improvised, and it's best played with a team. And the ACR whispers long before the kidneys scream. Now, there are two classic chronic, oh my god, it's taken over the Western world's healthcare things with ACR. Okay, well, there's three actually. There's heart failure, there's CKD, and there's diabetes. And annoyingly, they all have different thresholds for intervention. So, although I have a nice rubric for it coming up, it's not the be all and end all, okay? So, whiteboard review of the first presentation of diabetes. So, what do you do when a patient with diabetes walks right in that door to you? So, the first diagnosis, think diabetes. Okay, so a Desmond referral or start diabetes referral, they are really good for sort of like going through all the conservative stuff, describing what diabetes is. Really good patient friendly, supportive language. This is a disease they're going to die with and hopefully not of. So, it's always going to be a thing. Immunoflu, annual and pneumococcal once, and then ACR, anxiety and depression and apnea screen. Okay, these patients are often overweight, often obese, particularly at first diagnosis for type 2 diabetes. They all need an ACR as well. Okay, and the big numbers you're looking for are 3 and 30. Those are the big ones. And A and D, anxiety and depression. These patients often the eating is a psychosocial response, and the weight is a psychosocial response and a protective mechanism to unaddressed mood and unaddressed mental health. So, biopsychosocial, super important for chronic patients in particular. BP and bracelet. So, type 1 and type 2 should be wearing bracelets at all times to say that they've got this disease in case there's an emergency, because things present differently in people who have neuropathies. And guess what percentage of diabetics have a neuropathy? 70 to 80%, and that can be an autonomic, sensory motor, combination of both otherwise. Okay, so blood pressure, that's really important. NICE have multiple different criteria. I'm going to go off SIGN, which is the Scottish one, which tends to be a little bit more up to date, dare I say, but also American Diabetic, European Diabetic Association, they all sort of say 130 over 80, unless they're over 80, in which case you can be a bit more liberal, right? If life expectancy is less than 3 to 5 years, then we can be a bit more liberal. Education is SNAP, which is how the Australians come up with the conservative criteria: smoking, nutrition, alcohol, physical exertion. And then the two targets for your HbA1c, we don't do percentage here in England, is 48 and 58. Okay, and remember, if they do not have symptoms, which most don't, you need to repeat it within 3 months. 48 versus 58. So 48 means you start monotherapy, metformin, 500 milligrams with your evening meal, 2-week review. And 58 means that you start metformin, 500 milligrams, evening meal, 2-week review. But you also add to that something super important, which is a Q risk. Okay, so if Q risk, you start them on DAPA. If not Q risk, basically nowadays they should probably be on like semaglutide, your GLPs, right? So we're doing end organ damage assessment, so brain, eyes, renal, foot, and heart, and get them booked in for their annual eye and foot exams and renal profile. As we said, start immediate release metformin, 500 milligrams, evening meal, titer every 2 weeks, and then that's what we've said. So then what I've just included here is the management of hypos acutely and DKA as well. Yeah, that's more of a hospital thing though. So the differential of hypoglycemia now, the reason that is like that is because I wrote these out on whiteboards, so I just thought I'd include it there, just in one thing, because the screen was blank when I gave the talk. So the differential of hypoglycemia. So we're not just saying, okay, the A1C is up, therefore it's diabetes. The differential is donuts, okay? So damaged pancreas. So late onset diabetes, this autoimmune late onset thing, which is why probably C-peptide is becoming a routine thing even for your query type 2s. And then there's other like anti-GAD, anti-zinc, transport 8. There's all sorts of things, but defer to endo for that, and they're going to do that anyway. And type 1, but Yep, so that is the D. O is that they are off their meds. They're not taking the medications as they should be, and they're not subscribing to the lifestyle factors as possible. The N is a new diabetes diagnosis. U is under treatment, and then treatment itself. Okay, so the pill, thiazide diuretics, and loop diuretics to less of an extent. Your antipsychotics, but they should be on regular monitoring for this. Lipid profiles as well, and steroids, obviously, and then stress. So both acute stress and then long-term stress. All sorts of stress lead to elevations of the BM. I just thought I'd include a slide about this. So the non-pharmacological and pre-diabetes, this is very overwhelming for a lot of people. It's a lot of expensive lifestyle changes, expensive both cognitively and actually financially. It is cheaper to eat unhealthily easily, right? You have to eat healthily cheaply is more effort than to eat unhealthily cheaply. And effort does not equal, well, therefore you are lazy. Effort is overwhelm, other priorities, lots of other things going on here, and it's a silent killer like hypertension, diabetes, until it's not. And so cycles of change, right? So non-pharmacological approach, I'm trying to make the most evidence-based, simplest thing as possible. So a pre-diabetic gets intensive lifestyle for 6 months with bloods every 3 months, okay, for the A1C. We're looking for 1,800 calories a day, kilocalories a day. Mediterranean diet is the best evidence-based. It's probably the best studied as well. So it's not that this is the only way, but it's the best one that we know so far. They should be doing about 150 minutes of moderate intensity. And what that should come to is 50% of the maximum heart rate. There are many formulas online to very simply calculate maximum heart rate based on age and sex. And there are wearables that are incredibly cheap that measure heart rate. The patient can also take their own pulse and count it themselves with a pocket watch. So everyone should be able to do this. If that's still too much for the patient, it's unable to complete a full sentence because they're walking to such an extent, but anything is better than nothing. If the patient is struggling to walk for 150 minutes a week, again, anything is better than nothing. Slowly build it up. The other thing you can do is weighted backpacks. Weighted backpacks are a really good way to improve the efficacy of walking. So shove some books in your backpack, shove a bottle of water in the backpack, keep making it a little bit heavier. Try to do 150 minutes over the week. You can chunk it, you can do whatever you want, okay? Try to add resistance as soon as possible. So strength workouts are synergistic, they are unique in their benefits, and one of the big things that they do is increase insulin responsiveness. So they increase the amount of insulin receptors that we have present. So if this fails at 6 months and they're still pre-diabetic or diabetic, you should obviously treat. You treat now, ideally, a pre-diabetic as well. Okay, so what I'm doing is if the intensive lifestyle they've been concordant with at 6 months has failed, we start metformin and then you do a Q-risk and you add DAPA, 10 milligrams, fire and forget once the 2-week renal profile has been passed. Take-home message here is that we're starting to treat lifestyle-resistant pre-diabetes as diabetes. So now the stepwise management of diabetes, so pharmacological treatment from asymptomatic A1C to basal bolus insulin regimen up titration. So this is a really, I've just outlined it basically. So you can read this in your own time because it's very straightforward. Basically, the most important thing is start metformin, increase the dose to 2 milligrams BD total daily dose every 2 weeks. It used to be every 1 to 2 weeks, but 2 weeks is better because it's better tolerated. Most people's intolerability of metformin settles, so people quit a little bit early. If they can't tolerate, go modified release. If they can't tolerate, go DAPA instead and remove them off metformin. But metformin is super cheap and works, okay? It can do a lot for your A1C. So you should probably try to bias them on it as much as you can. Bloods every 3 months whilst you're on this up titration, and then every 6 months once they're stable. If they start with 58 as their A1C, or they're Q-risk positive, then you shouldn't just start metformin, you should go for dual therapy. So there are two different camps that UpToDate recommend. So if Q-risk cardiovascular only, add your GLPs, but if it's CHF-CKD, add your DAPA. Okay. NICE also say, hey, gliclazide, because it's incredibly cheap. So you start 80 milligrams, and every fortnight you're uptitrated to 320 milligrams at total daily dose. The DPP-4s are pretty benign. They don't really have many things that are an issue. So you can do that, but they also don't work very well for A1C. And your pioglitazone just has so many contraindications, right? Like, I just don't like the drug. I'm sure it's great for some people, but heart failure, bladder cancer, unexplained hematuria, bone health, it's just a bit of a nightmare. So not great. Triple therapy then should probably be metformin plus DAPA plus semaglutide, basically, but quite often in the NHS it's probably going to be metformin, DAPA, gliclazide. When your trip therapy fails, keep your metformin, keep your DAPA, keep your sema. Obviously, do not give a sulfonylurea with an insulin, because those are the two that cause hypos. And remember that sulfonylurea plus insulin plus your your pioglitazone causes weight gain. Okay, so not great. Start Lantus. I did say that sulfonylurea, insulin, and pio cause that, right? I didn't say sema. It's sulfonylurea. So when the triple therapy fails, they need to be on insulin. There is a growing amount of evidence that if they start on 58 or above, like NICE is saying, so start dual therapy, right? There is growing evidence that most of these patients need insulin at some point, and even then they struggle. So there is a growing movement to bring insulin in sooner. So it might be in the future that 48 to 58 you continue this pathway, but 58 you really start adding insulin sooner. So you shouldn't do that yet. I wouldn't say the evidence fully supports that, but just consider that for the future. So start Lantus at about 10 p.m. nighttime dose, 10 units and up titrate. When would you go Levemir BD? And the answer is if they're getting evening hypos, because it's all in one dose, right? So that's the same dose, but BD Levemir. The patient has patient-directed titration, so it's 2 units every 3 days, so 4 to 7 target, okay? So when you get to about 100 units a day total for Lantus, then you're going to fail. So what we do is we take that basal 100, we drop it down 20 to 30%, so let's say 80 units. And then what we do is we give each meal 10 units of rapid insulin, so NovaRapid, ActRapid, Humulin Rapid or whatever, and so each one gets 10 units. And then the one that has the highest glycemic spike when the patient takes their capillary blood glucose is the one at which we say, okay, add 2 units every 3 days and see if it controls that glycemic spike. So see if the basal bolus has worked. The data shows when you start at 10, it usually is 15 to 25 units per meal. This is a lot of patient-focused work, and hypos are a high risk. Missed doses are a problem, so you can see how this requires a lot of patient buy-in. So the other question is, what about ACR and BP? So if the ACR is 3, regardless of blood pressure, start them on an ACE inhibitor if the renal profile says it's okay. If the ACR is 30, regardless of blood pressure, add 2 ramipril DAPA, 10 milligrams, 2-week renal profile, fire and forget. Okay? ACR 30 plus CKD3 is adding that new mineralocorticoid receptor, finerenone, okay? Blood pressure 130/80 is the target for many, many things, okay? NICE say 135/85 for your exams. Unless ACR is 3, then 130/80. So ACR wins the day for that, but ACR 3 should be on a blood pressure med anyway. So 9 interesting brief case reviews which you can have a look through. So there's some and there's some more. So pause the video and think about how you would manage. All of the answers for this are within the slide, so we won't talk about it just in the interest of saving time. So thank you very much.